it's a very interesting thing to sort of debate what's going to happen with Obamacare relative to the Supreme Court decision and so forth and so on. And obviously the move, as we discussed at our speakers' dinner last night, the move toward service lines for traditional insurance companies is clearly accelerated by the cap on medical loss ratio and the notion that, being in the insurance business might be a little bit like being a power utility, right? You get a geographic franchise and you have sort of a guaranteed profit margin, and you're going to go to a rate-setting commission if you want to move on that. It's a nice way to have an annuity cash cow company, but it's not much of a growth story. So this is a logical move. But I think there are fundamental reasons why the insurance industry, even irrespective of the Affordable Care Act, was moving in this direction. United would be certainly exhibit A of that. The reality is that, and I guess I also want to just sort of call out other kind of unnatural acts perpetuated by health plans. You have, most outrageously, I guess, the acquisition of West Penn Allegheny Health System by Highmark, the Blues plan of Western Pennsylvania. So there again, a totally sort of vertically integrated entity, still pending approval from the Insurance Commission, but it's passed Taft-Hartley and other hurdles, so it looks like it's probably going to happen. And also, I would certainly encourage you, if you're an analyst or investor in this sector, go to the CareFirst website. CareFirst is the Blues plan in Maryland, and take a look, download the 80-page white paper they've prepared for the implementation of a patient-centered medical home in Maryland. It's an unbelievably complex and far-reaching transformation of relative to what health plans have typically done. They've actually gotten waivers from Congress and waivers from the Maryland legislature on relief from anti-kickback laws in terms of the structure of their plan, which incentivizes primary care physicians into medical home hubs. So anyway, just making the point that unnatural acts and radical disruption is happening in the payer industry. The final piece of all this is healthcare consumers. Let's not forget who they are. These are baby boomers, folks. These are the greatest consumers that humanity has ever produced. They are practiced at having their way with society's institutions, and they're now entering their prime healthcare consumption years. And it's one of the reasons why I was excited to have Jody Holtzman from Aarp on the panel. It may seem at first blush like an offbeat selection for this panel, but I think that you'll see a logic there. So here we'll do introduction in a second here, but very happy to have representatives from two of the companies I regard as among the forefront, aggressive, forward-thinking, and courageously transformational pioneers in the payer space from United and Aetna. Maybe if we could just go, starting with Brian, working this way to do some quick introductions.
Hi, I'm Brian Kelly. I'm a physician. I've been with Aetna for 4 years. I run informatics at Aetna. Before that, I was the head national medical director for our national account group. Before that, I spent 5 years at Accenture running their electronic health record practice and consulting with a variety of healthcare clients. And by way of background, I'm a 20-year Navy physician. I used to run the ICUs at Bethesda Naval Hospital. So really happy to be here.
Hi, I'm Bud Flagstad, Senior Vice President of Software Innovation and Technical Product Management. I've had the opportunity to work for United for 7 years. Prior to that, I worked for Definity Health, which was acquired by United as we were leading the CDHP programs under Definity Health. It was a great acquisition. It's been a great place to work since. Prior to that, I was in financial services, spent 7 years at some of the largest banks, working on back-end systems and helping automate some of the processes in banks.
Jody Holtzman, I'm Senior Vice President of Thought Leadership at AARP. We're focused on stimulating innovation that'll benefit people over 50, which is one of the reasons that I'm here. I come out of strategy consulting, and companies like PwC, brand strategy at Future Brand, and have been at AARP a little less than 7 years.
Thank you. Brian, starting with you, your CEO, I quoted during the introduction, has been explicit and dramatic in his proclamations regarding sort of the reinvention of Aetna. Can you summarize for us?
Well, thanks, Brandon. So, the mission at Aetna really is to make quality health care more accessible and affordable for all Americans and hopefully other folks around the world, too, as we expand internationally. We really take this mission very seriously. We're a value-based company. If you ever heard Mark talk, you'll hear him start almost every speech talking about how we try to put the people who use our services at the core of everything we do. And they're really, from a transformation perspective, we think there are lots of major, people that use our services, but primarily they're providers and there are members or consumers. And we believe that, the way health, to be a health plan in the future, and even now, has to be very different than what it has been in the past. You all know the background on, we've got a real, societal need, and we have an ethical reason for helping that transformation. So when we think about the new Aetna, we really think about an Aetna that focuses both on how do we work with providers to work with them to develop new, better delivery care mechanisms. And these are delivery care mechanisms. They may be ACOs, they may be a patient-centered medical home. As you heard in the prior panel, we're not exactly sure what they're going to need, but we know that some of the fundamentals are that they're going to have much better aligned incentives. But we tried this once before 20 years ago and it didn't work when we went to capitation. The way we really align incentives here is we do it in a partnership manner, and the big difference is that you support it with a technology stack. So when we think about the transformation, part of the transformation now with how we work with providers is to really think about how do we give them both the financial insight, the utilization insights, but also the technology tools to actually make this transformation successful so that they're profitable, they take better care of their members, and we all win. We reduce healthcare costs, we make healthcare more accessible and affordable. Now, to do this, part of the strategy has been to bring within the Aetna family of enterprises, companies that have capabilities that do that. So as many of you know, almost 2 years ago, we acquired Medicity, the nation's largest health information exchange. We have for years had Active Health, which, has market-leading both decision support and medical management capabilities. And we focus a lot on data analytics. I lead a very large group across Aetna that focuses on data analytics, and we're absolutely passionate about taking data, gaining insight, but then applying that in a meaningful way that, again, improves quality and total cost. The other group that we focus a lot on, in addition to the providers, as I mentioned before, are the members. And we do believe that whatever the path forward, the individual member will become more and more a more important person in the decision-making process, regardless of what happens to PPACA or however healthcare evolves. The individual, through CDHP programs, let's face it, they are going to bear more and more of the financial burden of their healthcare over time, and therefore they're going to need to be empowered to help make better decisions. So the way we look at engaging the consumer really is in three major ways. The first is that we try to focus on determining what type of service are they really looking at. I like to look at services really in two big buckets. There is what I call a commodity service, which is the way Mark likes to talk about quality services is the way that for a commodity healthcare service, such as getting a flu shot or maybe getting a prescription refill. That is a commodity service. I mean, the way most people would say that's a good experience is, was it easy? Was it inexpensive? Could I do it after work? Could I do it conveniently? Could I access it through my mobile phone? So, part of our strategy is our move to mobile, our move to, make these type of transactions easy. Can I find a doctor? Can I get the service I need in a commodities manner in very easy ways? The second way we look at healthcare is there are services that aren't a commodity. I was a neurocritical care doc for most of my life. If anyone in my family or any of my friends ever needs to have a brain aneurysm clipped, I can tell you where it gets done and by whom it gets done makes a difference. So we're committed to trying to help members navigate the healthcare system and understand through transparency tools, through quality tools, through cost tools, where can you access those non-commodity services in the highest quality and most efficient manner. And then the third way that we like to look at how do you work with the member is behavior change is actually critical to achieving outcomes, particularly when it turns to managing chronic diseases like obesity, diabetes. So how can we work with the member and make both access to services, access to wellness programs, touching the member more and more easy, convenient, and impactful? And so those are our focus. So the new Aetna really looks at how do we work with providers, how do we work with members, how do we bring tools and technology to really make that effective.
Thanks very much. That's a lot, and we'll be coming back to those themes. Bud, United has for a long time differentiated itself from other payers by virtue of its service businesses, many of which have competed with United's other customers, which is a nice trick when you can get away with it. There have been a lot of changes there as United has responded to these same market pressures. In fact, you yourself have a different job, I think, now than you did when you accepted the invitation.
Might have even changed today, I'm not sure. right. Or after today, depending on how it goes.
Or after. Well, this is being taped. Could you summarize for us, just react to and contrast, especially to Brian's characterization?
I think United has really since, the company was formed in 1974, went public in 82, and really started to make that services separation in 1998. I think Steve Hemsley, our current CEO, as COO back then, saw the opportunity in the future with respect to services and really started placing benefits and services in their own separate spaces. And then last year, we really brought them together, brought services together. You saw the Ingenix brand kind of fold into the Optum brand, now being called Optum Insight, Optum Health, part of Optum, and Optum Performance, and Optum, and Optum, and Optum. And you're going to see more and more about Optum throughout the year. Did I say Optum enough? Because I think I paid for that too. It was something that was very interesting to watch. And as being an acquisition from Definity Health, and I remember sitting in my office and somebody told me, hey, we have this bank. It's called Exante Bank. And I go, why would we ever be in banking? That doesn't make any sense. We should just partner with banks. That's not our core. You know, that was open. That was started in 2003. And if you look at Optum and Optum Financial Services now, it's got $1.6 billion in assets, 840,000 accounts, and it's pretty amazing. And I would have never seen that, but our CEO and COO and CFO at the time thought ahead and thought about those things. So what's really cool about it is I kind of sit in the middle of that, and I try to learn as little about how healthcare was done, and I think about how healthcare could be done, and that's kind of my role. And I get to use these large tinker toys, if you will, of opportunities. And you look at our call centers that take 350 million calls a year. We do 2 million claims a day. Just an amazing scalable program of solutions out there that I can leverage to help start building innovation through our R&D organization and partnering with companies externally. And that services business has become a big part of where I work. I spend a lot of time with the Optum brand, and I spend a lot of time with UnitedHealthcare, spending lots of time helping them develop and come up with new ways of serving our customers, of which we have about 73 million today, and very fortunate to have that kind of business.
Terrific. Thank you. Jody, when you and I first met, I was sort of astonished to discover the scope of AARP's engagement in the insurance business. I guess it shouldn't have been as much of a surprise, but love for you to summarize for this audience your posture relative to this marketplace, and also just quickly touch on why you're here.
Sure. Well, first of all, Brandon, thanks for putting me on stage with my two partner companies. Our
we aim to please.
What's that?
We aim to please.
Right.
We're all about synergies here.
So AARP does not have its own insurance products, right? We partner with others. They pay us a nice royalty for the use of our brand and exclusive access to our members. So our major medical product for the 50 to 64-year-olds is with Aetna. Our Medicare supplemental product, our Medicare Advantage product, and an indemnity product are with United. There was a time when actually AARP effectively made United, and was a huge book of their business, and then they decided to do a couple of acquisitions. I'm here because, well, first of all, our mission is to enhance the quality of life for all as we age, and clearly healthcare is core to that. You got 100 million people over 50 and growing. I'm looking around the room, some of you here, and the fact is that about a third of that 100 million have significant health issues. All right, the other 2/3 are mainly people like in this room who get up every morning and got stuff they want to do, stuff they got to do, and they get on with life. But core to what we want to do is ensure that there's coverage, and core to AARP's mission actually is healthcare. So the story of AARP is that a former principal, the first woman principal of a high school in California back in 1935, Ethel Percy Andrus, in the late 40s was looking for a retired teacher, couldn't find her, and turned out she was living in a chicken coop in a backyard in California without health insurance. And Ethel decided that retired teachers had to have health insurance, and could not find a single carrier in the country who would cover retired teachers because the actuaries said that they were bad risks. So she went, and that was the story of Colonial Penn, and that was formed, and that also had its own story. And over the years, we've continued that thrust, that health coverage and health security are really core to our mission. And it's also core, frankly, to our revenues. So AARP has 37 million members, $1.4 billion in revenue, and about 2/3, 3/4 of that come from royalties that we get on for the use of our brand on various products and discounts and things like that.
And part of what Jody's doing is working as sort of an advanced scout for AARP to highlight and identify emerging technology companies that can be of service to the membership. And I can personally attest that he's been very responsive and really done a great job of triaging suggestions we've made. I think it's worth highlighting, just sort of tagging up on one of the sort of principles of investing in our sector that I'm sort of reminded of this from your comments. Our healthcare system in America, as exciting as it is to sort of talk about wellness and disease management and patient engagement and much of today's conversations relating to, for example, mobile technology focus on where the sort of change is occurring in the healthcare system. But it's worth tagging up on a couple of truisms here. Look, our healthcare system in America is optimized for the elderly. It's optimized really for the frail elderly in the final months of their lives, right? I mean, it's worth reiterating the statistics. 80% of your lifetime healthcare consumption dollars are going to be spent in the last 18 months of life. 80% of Medicare dollars are spent on patients with 5 or more chronic conditions. The reason we have such a highly evolved inpatient hospital system infrastructure in America is that we're really, really good at providing acute care to frail elderly in the last months of life. And what we're trying to do, and much of what we're trying to do that's exciting, is sort of catch up and begin to push healthcare access and quality sort of earlier in people's life cycles. But it's just worth remembering that when you look at current budgets, infrastructure, attitudes, and momentum, it is our healthcare system is about the elderly to a very large extent. Okay, I wasn't going to ask this question, but we had such an interesting discussion at dinner last night. If the Affordable Care Act is overturned in part or in whole, and I heard some interesting arguments 2 weeks ago out at the HEP conference that made me think for the first time that it could be overturned in whole. Where does that leave the strategies that we just articulated? Does that change anything in these general attitudes? And again, I'm making note of the fact that a big part of the impetus behind, I would imagine, the Aetna transformation is this notion that it's not a lot of fun to be sort of a commodity insurance provider where profit margins are sort of capped forever. What does it change anything if we get a reversal in June?
I guess I'll start. I actually really don't think it changes our strategy really at all. I think that the forces out there right now are going to require us to develop new models of healthcare if we're going to succeed as a country, and we're really committed to covering, people. So if what will change if PPACA is overturned is probably obviously the rate of change and how things will proceed. I mean, the good news about PPACA is that there's one set of directions that we would know and we would be moving forward with. If PPACA was overturned, then nature abhors a vacuum. The states are going to very quickly step in and develop their own solutions. And quite honestly, I think that will be more difficult for all of us to navigate because we'll be dealing with many different variations of regulations as opposed to a single federal mandate. But I think that we as a company have to help develop better models to deliver better health care that's more affordable. And regardless of that, our focus is absolutely, as a company, we will be 100% compliant with whatever regulation is the law of the land. But we've got a core mission to even do better than that and to really develop the models that are actually going to help all of our citizens. So I don't think it fundamentally changes our strategy at all, Brandon.
Mm-hmm. Bye.
Yeah, and I echo what Brian just said, which makes it a lot easier for me to say something much shorter because he covered everything I would have said. Thanks.
Sorry, you go
No,
first.
no, absolutely, no.
Absolutely.
No, I'm glad you did because you say it way better than I would. in all seriousness,
The companies really ought to just merge. I mean,
We do, yeah, absolutely.
I'm open to it. How about
Okay,
you?
I'll talk to Mark.
But I mean, I asked my team this before I came out here. I go, do you think this will change? And the comment was the agenda is the same for us, no matter what. It's really delivering better outcomes and more affordable health care for consumers. And I say consumers versus members because I think because of our size, we have the ability to move the market towards a direction. Making things better as a company is really the goal. And, I hear that message consistently from our CEO as well. I feel he's really passionate about helping change healthcare for the positive. So really excited about it. No matter what comes, we'll adapt as a company. We always have. And we'll address whatever needs to be addressed to make ourselves successful and ultimately make our consumers and members successful.
Yeah, I think the thing that, with ACA or without ACA, the fact is that we have to find ways to reduce costs in the system, and that means better health outcomes, right? Worse health outcomes, the costs, go up. For our constituents, that means finding ways to enable them to live independently, to age in place, to be social, to be part of their communities. When you're part of communities, you're less isolated. If you're less isolated, you're less depressed. If you're less depressed, you're not going into a health tailspin. So, to me, it's really, I think what's going to happen, what's already happening and will happen more is that people will start to see that all of these health outcomes really are driven by much more of a holistic approach to the person's life. And, then the question is for us, and, one of the questions that you had raised, Brandon, is what are the technologies, that we would be looking for. It's all of the aging in place technologies, it's remote monitoring. You put a 50-cent monitor in a scale in somebody's house, and you're able to see if there's a spike in weight on any given day, which is an immediate red flag about a possibility for a heart attack. And if you can intervene before that happens, well, it's good for the person, it's good for the person's family, and it's certainly good for the cost to the system. I think the question going forward is who pays for that. And, hate to be the nonprofit guy that, raises the issue of who pays, but, whether it's, I think Medicare over time, once it is so obvious that the costs will be reduced by these technologies, I see Medicare eventually, coming to that. However, in the near term, I've recently just, concluded that if I were to come out with my crystal ball, and I used to work for John Nesbitt in the Nesbitt Group, going back to Megatrends fame, and so you pull out your crystal ball and where are things going? I actually think it's these guys that are actually going to start to cover those costs, and it's going to be just that they're going to save money. It's as simple as that. And for us, it's going to be everything from not just remote health monitoring and sensors in the in the scales, but it's going to be about connected living and enabling people to live independently. And that's not living in an isolated way. That means living in a social way as well. And I think that's what gets you to better health outcomes and lower cost.
Yeah, it's worth another, I guess, truism worth tagging up on is the misaligned incentives that appertain to wellness and prevention, right? I did a consulting engagement when I was at business school for Johnson & Johnson, who had a health management subdivision, JJHMI, I think it was called, and they would go into Fortune 50 employers and run sort of their internal wellness programs. And it was pretty clear once you talked to the customers that this was a nice employee benefit and kind of retention tool, but in terms of bending the curve on their actual healthcare expenditures, they didn't have much confidence that the investment they made today in obesity or smoking cessation or breast cancer would accrue to them, because in 5 or 7 years their patients would be working for someone else, or those diseases wouldn't manifest themselves until patients on Medicare. So capturing that closed ecosystem is certainly a dysfunctionality that's sort of woven into our healthcare system. And you touched on the point when you said, hey, at some point we need to wake up as a society, and maybe now's the time, and acknowledge that these early investments are worthwhile. But again, how does that happen? I'd like to kind of go next and amplify something you just touched on. All three of you have mentioned the renewed importance of focus on the individual member. Dave Tamburi from Health Enterprise Partners, we were in a meeting last week, and he trotted out a statistic I hadn't heard before, which is that the average family of 4 annual out-of-pocket expense for health care had increased 130% in 10 years. In other words, the average family is paying an awful lot more out of pocket than they used to. But you're from the world of Definity, which is one of the leading consumer-driven healthcare companies that United purchased. Brian, you mentioned the importance of catering to the individual. Could you talk a little bit about the sort of the renewed emphasis or interest on the payer for the individual as a person? This seems to me to be the key to this whole sweeping trend of patient engagement.
I should probably start since
You
I
should,
threw Brian under the bus a minute ago. So as Definity, interacting with the member, giving them the tools to really become consumers of healthcare was critical. I kind of had an epiphany a few years back when I traveled to India, and I watched how in India they're consumers of healthcare. And for many, many years, this is my words, not my company's words, the United States is more entitled to healthcare versus how in India they're consumers. But as the high deductible wallet share starts to shift, consumers need tools to ultimately help them figure out the best way to move through the healthcare system. And I think we're starting to see that. In the past, payers have typically sold to employers who ultimately told us as employees what we got for healthcare. Now they're getting more and more choices as things start to evolve in healthcare. And without those tools, people can't make really good choices. So we've started to build tools to do that. We've got the Health for Me app that we shipped earlier this year. That's significantly a tool that is getting great reviews from our customers and our members, ultimately.
Hey, Bud, what's it called?
Health for Me.
Health for Me.
Yep, it's available both on Android and iOS. Please download it and say positive things. Thank you. We'll do the healthcare cost estimator very shortly. Will be coming out. We're certainly involved in giving consumers those tools. And we used to joke people spent more time deciding what TV to buy than what healthcare decisions to make, and I'm guilty of that for sure. And it was an interesting experience recently where I had to go in for an ultrasound. It was nothing serious. And I walked up to the desk and I thought I'd ask the question, how much is it going to cost me? And the lady said, I don't know. And I said, well, is there any way to find out? She goes, well, all insurances are different, so we really can't tell you. So I was walking into a room, which is ironic, right? I'm part of a payer organization. Certainly could have asked for some insight, but I wanted to ask the desk at which I would send a check eventually. And to learn that they can't tell me is just part of the frustration for all of us. And so we need to get to a place where we can give consumers that kind of information, because none of us are going to go to Best Buy, pick out a TV, just tell me what it costs after you ship it to me. That's just not going to happen. So I think building these solutions and tools and helping the consumer be better consumers in healthcare is critical.
Yeah.
So I spent my first 2 years at Aetna as the National Medical Director for our national accounts, which is all of our large, over 5,000 employer groups. And I'd never been in health plans. I've been a Navy doc most of my life. So this was a little bit of a culture shock for me. When I started going to visit this, and over my 2 years in national accounts, I visited over 400 different clients across the country, or consultants. And what really became so critically clear to me was that from an employer perspective, the healthcare costs were unsustainable. $1 million in healthcare cost for our major companies is 15 jobs that will be lost next year. Simple as that. Every $1 million healthcare costs go up for a lot of these companies. They will fire 15 people that will then not be employed, and you can think about what that does to us as a country. The strategies that these employer groups are taking is not surprising. They're trying to, they are the data that Brandon talked about, moving more and more of the share of the co-payments and more the movement to CDHP programs is absolutely a market trend and will continue. When we go to the exchanges, things will only get made worse, because on the exchanges, even though even at the base products, there's a set of covered benefits. If you go to internet-based purchasing, if you look at the airline industry or other industries, what you'll quickly hear from them is 90% of every buying decision is made only on one parameter, and that parameter is price. So if you think about the bundle of services in that offering, it's going to be determined primarily by price. This is all a way of saying that people are going to be much more empowered. Now, to say you've got a problem, but we don't offer them solutions is really not where any of us want to be. And I will absolutely agree with Bud that what we have to do is we have to educate people on both what is quality care and what is cost-effective care, and where is it a commodity service and where isn't it a commodity service. And we have to make it easy and convenient for the member to do that. So less than 12 months ago at Aetna, we acquired a company called iTriage. You'll hear from Pete Hudson later. But essentially, it allows people to, when they have a problem, find out what the diagnoses could be, suggest a place of treatment, and over time, it will actually, right now, it allows them to actually make appointments with physicians, and that will be more and more integrated into the Aetna products and services over time. For several years now, we've had something called the Member Payment Estimator, where an Aetna member can find out to the penny what it will cost for them to get a set of services or procedures before they go into the physician's office, and to price compare 10 different choices. These type of tools are going to be critically important, as Bud mentioned, to empowering the member to be able to navigate the healthcare system, know where quality is a differentiator, know where cost is, it's a commodity service, where cost should be the differentiator, and begin to do those type of, make those right choices. The other thing that I think we're going to see more and more of is how do we actually work with members to have them lead healthier lives and reduce obesity and diabetes and many of the other factors that are driving such huge cost in our healthcare system. If we stay on the current medical, wellness trajectory that the country currently is. There's not enough money in the whole world to pay for U.S. healthcare. So to me, that's the final frontier. And the organizations and alliances, and it's going to take alliances that can actually bend the outcomes of wellness, is how we're really going to make healthcare better in the long term.
You raised an issue, and it struck me that there's a real difference in the time outlook, the time horizon that people are making, purchase decisions. So as a consumer, if I'm buying that TV, I'm just thinking I need another, 5 inches because the space in my cabinet is such, and I want a bigger picture, and I, balance that versus the cost, and, do I get a newfangled Wi-Fi enabled one, or do I get a Roku and an Apple TV box for $100? Those are very near-term decisions. The fact is, with healthcare, it's long-term decisions that actually are the things that are going to influence both the eventual health outcomes and the eventual costs, particularly to the payers, but also to the system, as a whole. And I think that it's absolutely unrealistic. If all we were talking about was shifting cost, right, then it's really easy. There are lots of ways to just shift cost to the patient, and then give them tools to find out how to lower the cost the percentage of the cost that this increased cost that they're bearing. But there's this other thing here called health outcomes, and if we're in agreement that is the key to lowering costs to the system, well, then that's a whole different thing. So to me, the question is, who's going to make the near-term, consumer choices, and who's going to make the long-term investment choices? And frankly, I think the burden is less on the individual, even if we accept, and I do, the shift to, quote, consumer health care. But I still think it's on the payers and the system as a whole, not the consumer, where the long-term thinking is going to go, because people are, just to your point about buying plane tickets, they're always going to be driven by the cost. And one example of that is one startup company. It's called Extend Health, and Brad from Match Point help with this. It's backed by Silos. It's just filed for its IPO. Created, and our products are traded on the Extend Health Exchange. The fact is, people see the price comparisons for what's there, and they buy on the basis of price. And they do it very well, to the point that Extend is now filed for their IPO. So, I mean, from a business model, it makes lots of sense. The question is, at the end of the day, what are going to be the health outcomes, and what will be the cost to the system as a result?
Jody, I'll give you sort of two responses. When I look at, I think that there is an opportunity, there's a short-term opportunity to absolutely help consumers make better quality and affordability choices in the short term. I think that's a huge opportunity. I get to look at all the data across Aetna, and we're in almost all the major markets. In any given market, the difference in the cost of a specialty service, a scope, an MRI, an arthroscopy, a procedure, typically varies 300 to 500%. Okay, what other industry has that type of variability? And part of it has been there's been a lack of transparency. So there's a huge opportunity. And again, I would consider, I've had a colonoscopy. Colonoscopies I would define as a commodity service. They're pretty much all the same, okay? So, really, that decision should be made predominantly on price, provided that you're going to, a quality network in general. Hospital services in any given market, typically 80 to 120% variation in the price of service. So someone going in for a routine, delivery, typically it could be $8,000 to $20,000. Again, typically with generally at a macro level, similar outcomes. Primary care services have nowhere near that variability of pricing. They're usually about 20%. But that short-term opportunity, if we can help consumers with transparency tools, I think that's a real opportunity to make a difference. The long-term wellness and obesity changes, those are much more difficult. And this is where I actually believe behavioral economics and how you actually work with a member over time to drive and incent them to do different things for their own benefit and the benefit of their family really gets really becomes important. And long-term relationships with the member to do that are important. If you have someone changing their health plan every 12 months, why in the world would the health plan or anyone or them invest in different products and services? But if you knew you were going to have this person for 15 or 20 years, then it becomes a lot easier to say, we really need to incent you focus on wellness programs, and we need to incent. And behavioral economics, believe me, that's going to be where a lot of these advances are made. We've done some neat modeling and talked to a lot of others. And what's fascinating is that incentives and disincentives have very, very different impacts on behavior at the same monetary value. Also, if I paid you to do a behavior, but then I told you that I was going to give that money to your daughter or your wife or someone else you cared for, we would drive dramatically better behavior in you by saying we're going to give the money to someone else. So these social networks and these behavioral theories of how we actually change outcomes become very important. And I actually think long-term strategies around that through long-term partnerships. And again, partnerships with communities, with lots of other. It can't just be United, Aetna, a hospital, a provider doing it. These are going to require very different models and alliances to make all this stuff happen.
So that all sounds great. There's always, I think if you're moderating a panel, there's always a temptation. Do you want to be Charlie Rose or Mike Wallace? So I'm going to be Mike Wallace a little bit and push back on that. I was in a presentation with Jeff Margolis, the TriZetto founder. He's raising money for a new sort of patient engagement site. And one of his slides, which I think is pretty interesting, he sort of lists the health plans by the number of membership and then by the number of Facebook likes, and I think it was United actually, wasn't it? Had 80 million members and 2,500 likes. Well, that's a company that's not connecting, right? And I think Aetna was lower on the list still. So these are companies that are not connecting with the end user, and I totally agree. Those are the places we need to go. I've probably seen 30 sort of patient engagement type companies. We're invested in Vitals, which is very much about decision support for the interface between the payer and individuals who, because end users don't trust ratings that the health plans themselves will generate, et cetera. How do you get there? So that sounds wonderful, but how do you get there from here? And is there, maybe comment specifically on, does it take a disinterested third party to sort of broker that relationship?
This is where it's interesting. First of all, to be fair to any individual payer, the two most loathed industries in the United States after you get past the government is the insurance industry and then the pharmaceutical industry. So it's broad brush, and that's long-term trend. It's nothing you guys did recently.
We worked hard at it.
That's right. But to the point, and this gets to the intellectual dishonesty about the issue of whether or not services are withheld in the United States around healthcare. And the fact is that every time somebody's more out of pocket, the same time that they go to something, they think it's covered in the plan, and then they find out that it's not covered at all because they didn't read the small print, and probably a lot of it is on the individual. But frankly, that does not matter in terms of this issue. People are ticked off. And I don't see that really changing because the economics of the business are going to be, this is going to be covered, this isn't going to be covered, and then there's going to be the person that has something that they think is covered, and then it's not covered. And that, just multiply that, by millions. I think that's a structural thing in the industry. Did I defend you guys well enough?
Thank you. You know, you
Yeah.
did well. You know, I think, you know, if there's been one, you know, if you think about the whole healthcare reform debate over the last several years, I actually think one of the positive attributes about it is that people realize that we have a problem with healthcare. Even those that have healthcare realize we have a problem with healthcare from an affordability perspective and from an access perspective. And I actually think that has been healthy because I think that people are beginning to recognize that, you know, if you want everything, if you want ubiquitous choice, if you want everything covered, there's a cost to that. And it's as simple as that. And actually, I think CDHP programs are actually driving people to obviously make those choices. But you would say, well, then, gee, is that having a negative impact? We've actually been studying CDHP programs for the last 8 years. And while I'm sure everyone would like to have a broad access plan that covers everything and not have a CDHP program if you gave them their choice. But if you asked them if they would pay an extra $2,000 for that other plan, I think most people would actually choose the CDHP plan. Every year we've studied our CDHP plans, we've actually seen that they get better preventive services, they are getting all their covered services, their outcomes are, if anything, better than non-CDHP programs. They are spending less, their employer is spending less, and they also use internet tools, they do more searches, they engage and use our PHRs far more than non-CDHP members. So while I'll absolutely agree with you, Brandon, people like to, you know, I mean, we're not the most beloved industry. I actually think that people are understanding that there are financial implications of our current healthcare system, and that we all have to work together. We cannot do this by ourselves. This is why we're very excited about new partnership models with providers, a better alignment of incentives, better alignment with consumers. We think that is the right way to go.
Yeah, and I agree with Brian and Jody as well. And you know, I think part of the situation, the opportunity for us is to inform consumers what is part of the program, what is free, keeping them aligned with realizing they need to go in and get their prostate checked and things like that, because people just don't know. They don't know what to do in some cases. Yeah. Simple as that, making it clear, hey, you're turning 50, go do this. Yep. And it's covered. We want to make sure you understand that. That's how important it is. You know, we are incented to keep people healthy as a company, and it's really important to us. I think part of the challenge is getting the message out and helping people understand what's there for them.
I didn't get that email or postcard when I turned 50.
Right.
You know, let alone when I turned 50.
You sure got a mailer from the AARP, though.
Well, there I did.
Partnership opportunity.
We have it in banners, you know, just hanging.
That was a shocker. I was handling my 50th birthday just fine until I got that. So just to key, and we better move to questions here in just a moment. So get your questions ready. Who was it in the last panel? It was either Al or maybe Kaveh who said that surveys of hospital patients have shown that the sort of hoteling model is not what people call patient satisfaction. What they really want is sort of insight into their treatment. They want transparency. I think actually that same metaphor probably applies right here. We're not necessarily interested in our health plan and our engagement with the healthcare system to be touchy-feely, warm, and embracing per se. I think we want to be dealt with like adults. We want transparency. I think I said last year in my opening remarks, and I think it's worth reiterating, you know, they teach you in business school that the three components of a high-functioning marketplace are, you know, a critical mass of buyers and sellers, you know, very low transaction costs, and good information. And without, you know, if those three elements are present, you can have a lively market. Well, healthcare is, you know, part of what's screwed up about healthcare, as we've been articulating, is the opacity around price. You know, the two most important things about a buy decision, price and quality, are opaque. And I think fixing that goes a long way toward making people feel better about the cost benefit of the care there. Anyway, that was editorializing, not a question. We should throw it open to questions now from the audience. Our microphone, Jeff Pardo.
It sounds like a significant part of what's being discussed is how do you affect long-term outcomes, wellness of patients. I believe there's a statistic that patients stay with an insurer for 3 to 4 years. So how do you do that knowing that I mean, can you identify those members that are going to be with you for a longer period of time, how do you actually start to invest in your member population with that sort of, I guess, membership lifetime with a particular insurer?
So I'll just say it's a bit of a challenge. I mean, I think if you think about the large payers, we've got really two major populations of patients. We have our fully insured and we have our self-insured. And most of our self-insured, these are insured through their company or through their employer. Many times it's the company who will actually invest with us and their members. And those tend to be the companies that tend to make the biggest investments in wellness and long-term productivity type of offerings are the ones that typically hold on to their members for the longest period of time and have workforces that tend to be older. If you're a company with an average age of 23, then you may have who turn over every 2 years, then you're probably not going to invest a lot in chronic disease type of programs, because that's not going to be applicable and you're never going to see a benefit from them. On our fully insured, I mean, we offer what we believe will actually be impactful and make a difference. And, we have a lot of actuaries that study this stuff all the time. I like to say when I joined Aetna, it's true, I had actually never met an actuary. Now 10% of my friends are actuaries, and it's growing at 2% trend a year. I mean, it's really amazing. So again, we make...
So some of my best friends are actuaries.
Some of mine are too now. This is really good. So, but the idea is that we try to apply logic and good business sense to where we make the investment. What I really believe, though, is long term. You could see models of offerings we have that would be priced differently if we knew you were going to be a member for 10 or 15 years, and they would make a lot of sense. Now, the government, I mean, the good news about the Medicare program is once you're 65, they got you, and they got you to the end. So it's areas like that where long-term investments really, really, make a lot of sense, and we see a lot of focus.
Continuing.
You're good.
Continuing in this theme, recently there's been in the literature that the disease management programs, particularly the ones that have a gain share aspect to them, don't work so well. Are you thinking of the Aetna there? Are you, when you partner with an employer, are they doing gain sharing with you? Are they just paying a fee?
So I mean, most of our programs right now are fee-based. What I would sort of my response to those studies that have come out is, I believe that there are a lot of things that actually are going to determine, whether disease management programs are impactful, and show the value that they need. I mean, there's a lot of things that have to come together to make these programs. So I look at across our Aetna, and I look at our different customers, I look at our different large employers. Some of our customers are seeing significant benefit from these programs and that we're offering, and it's the same for United, I'm sure, and the other major carriers. What I would tell you is, it's not only the fact that you have a program out there, it's the leadership of the company in actually showing that a culture of health is an important value that company has. It's also how you set up your plan design, how you set up your networks, exactly the medical management model you're delivering, how you set up your incentives, your disincentives. All of these things reinforce each other and can drive meaningful behavior and meaningful outcomes. So when, this is why I actually, we're at Aetna, we're a big believer of integrated programs. And we like it when we have not only your disease management, but your behavioral health and the core medical and the dental and the disability and the EAP, because these things can reinforce each other. And if you have a great relationship with a client who is setting the right culture, is messaging it rightly, it really makes a big impact. So that's kind of my general response to why I think there can be value in these programs.
Yes.
This is for the payers. Aren't we expecting a lot of the consumer? I mean, the consumer, most of us didn't go to med school, don't understand what the right protocols are. And then as Brian talks about, there's two different types of costs. There's the commodity type things like MRIs, where we want to push towards the lower cost, and the consumer and the benefits management companies will all work with you to try to help lower those costs. But then there's everything else. I got, someone gets diagnosed with some cancer and the costs go off the table. It's just about quality. It's about, I will do anything to help my family member to improve their outcome. So, but the consumer doesn't really understand or doesn't know how to figure out where do I go, which doctors to go to. And I don't think the payers do a good job of laying out the tools and IT necessary to help the consumer figure that out. So what's being done to help in both scenarios? So both, obviously you can improve it's easier to improve the commodity type things and educate people that MRI is MRI, to let's get the cheapest one, and then we'll figure out where to go from there to help someone read the MRI.
And you have all of 60 seconds.
Real quickly, so we have internal processes where people do call in with those kind of questions, and we do try to guide them to specialists to ultimately help them find, in the cases of cancer, unfortunately, we try to help them find the best solutions for their situation. We continue to work on those processes to make them better, because you're right, most of us aren't doctors and don't know exactly what to do. And those kind of interactions are critical for us to help guide people early on in the stage to get them to the best outcomes at an affordable, reasonable cost.
But I do think that if there's a third-party concierge, out there that doesn't have a vested interest in, the particular payer's, bottom line, and has multiple, clients across the carriers, frankly, I think that's a much more trusted source.
I also think that the new models of healthcare are really going to help here. So if we have relationships with accountable care organizations or oncology-based medical homes, so to speak, and we align incentives to that, we pay those oncologists better to drive better outcomes, and outcomes being defined really as they should be, that the oncologists will be motivated more to do the right things, to have the right discussions, to engage in compassionate care. One of the wonderful things that just came out of the Oncology Society just literally a few weeks ago is that they actually came out for the first time and they said, here are 6 things that shouldn't be done if you're an oncologist. And one of them was, if you have someone with very, very bad functional status, you should not start them on chemotherapy because it's just going to make them sicker. They're going to die faster. It's going to spend a lot of money, and you're going to, make them worse. Those type of financial alignments in new business models, I think, are going to be hugely important.
Well, thank you very much, guys. It was really great and generous of you to be here.